So currently, now that we have multiple options available for frontline treatment with patients with metastatic kidney cancer, none of the current regimens have been directly compared to each other. And so we have to use various clinical factors in trying to select what the optimal regimen for any particular patient is. So typically the considerations that I include are, what is the risk status? We discussed this earlier. There are two primary risk scoring systems that are utilized for patients with advanced kidney cancer. The older MSKCC system is based on the cytokine era, and the more recent IMDC risk criteria based on the TKI era prior to the development of immunotherapy. We know with the current standard frontline regimens that the efficacy is not consistent across all of the risk groups. So for this reason, I think that it's important that all patients, when initially diagnosed with metastatic disease, undergo risk classification using one of these systems. I personally use the newer IMDC criteria. Other considerations include, what is the burden and status or sites of disease? How symptomatic is the patient? As I mentioned, the current regimens we use haven't been directly compared to each other. However, looking at the response rates across the trials, it appears that there may be differential responses depending on the regimen. So for example, if we have a patient who has a higher burden of disease that's symptomatic and we need a quicker response rate, or a higher likelihood of response or lack of progression, that may influence the regimen selection. What are the sites of disease? Does a patient have brain metastasis? That may impact which regimen we utilize. It's also important to consider comorbidities that a patient may have, as it may impact the potential toxicities. For example, does a patient have poorly controlled hypertension or underlying cardiac disease? Does a patient have autoimmune condition, and a serious autoimmune condition that may preclude the use of immune checkpoint inhibitors? And then finally, what's the general fitness of the patient? For patients that are more frail, that I have some concern that may not tolerate the use of high-dose corticosteroids in the event of a serious immune-related adverse event, that also would influence the selection of a regimen. Other considerations also are the method of delivery. Some patients have a preference for or against oral versus intravenous therapy. There is a convenience certainly to intravenous therapy only, and having to come to the office every 3 or 4 weeks. Some patients don't like to be bothered by an additional pill burden, as often patients with advanced kidney cancer have other comorbidities and often are taking multiple additional medications. So patient preference in terms of mode of delivery should be considered. And then, of course, the side effect profiles for the classes that we consider, the VEGF tyrosine kinase inhibitors, have a very different side effect profile than the immune checkpoint inhibitors. This is considered in the context of comorbidities and patient fitness. We know that the VEGF tyrosine kinase inhibitors tend to have common gastrointestinal toxicities, hypertension, that needs to be accounted for based on the patient's other condition. Additionally, immune-related adverse events, and specifically immune-related adverse events, present differently than what we typically see with the TKIs as well. With monotherapy, immune checkpoint inhibitors have a low adverse event rate. It's more common with dual therapy, but the presentation often, although less common, is typically more serious than we see with the VEGF tyrosine kinase inhibitors. So the AE profiles and the differences also need to be considered when selecting a regimen for patients.